So if it is progressive, we have a social option. If it doesn't progress, if it is stable, then we have to do spectacles at point of time. But
which is very less compliant among Indian scenario. So when we combine this collagen cross-linking with topo-guided refractive corrections along with the regularization of the cornea, it results in it flattens the cone peak, resulting in flatter and broader cone, thereby redistributing the biomechanical strength. So CXL will have an additive effect on this. So resulting for a patient who is having best vision with rigid contact lens can accept better vision with only spectacles. So this is usually done with a refractive coordinated system. I have this system, and there are many other platforms to conduct this. But one specific thing about this refractive coordinated system supported by Zeiss is highly predictable values can be attained in post-operative period. Initially, for all keratoconus patients, we see for the progression. If it is progressing, then we will take him for the study, and he'll undergo all routine clinical examination and topography, followed by the complete manifest refraction has to be known. A good refraction is a key for this success. Followed by we get an imaging by Atlas topographer. This is actually Placido based imaging, which takes anterior sagittal curvature into the picture, and the same data will be transferred to CRS master. This is all linked by one another. So in CRS master, this is a main workstation, which here we have to enter pachymetry values and a manifest diffraction and optical zone. Here we can interplay between 5.5 to 6.5 mm depending on the corneal thickness, and we have to choose a topography treatment. When we actually do that, it actually shows our ablation pattern exactly focusing on our cone. So that can be further confirmed by like a 3D representation CRS master provides it. So when you actually see, there is so much of irregularity on the cornea, which can be tackled like a sure shot. So followed by that, we transfer the data to MEL 90 machine. In MEL 90, we do a regular PRK for it. It's followed by like alcohol epithelectomy, followed by a PRK. The normal PRK takes at least 2 seconds for every diopter. That's one of the fastest laser available. That is MEL 90. But here it takes about 18 to 20 seconds for every treatment, because here when you see the ablation pattern, initially it treats cylinder, then it causes regularization of the cornea. Then we expose it to mitomycin C. Our standard protocol is about 120 seconds, irrespective of the power treated. Then after thorough wash, we will do accelerated collagen cross-linking. How is our study different from the existed one? So like whatever the protocol which has been like published in the literature, they say like conventional C3R will be done after topo-guided treatment, and the considered thickness of up to 50 microns of ablation. But here we do usually 80 to 100 microns. Then which can be later on confirmed objectively, because we need some objective evidence. If you remember the previous slide where there was so much of cone and irregularity, which we have totally flattened with our treatment. So this needs to be like represented by a topography again. When you actually see, there's a topography flattening of almost like 4.5 diopter K-max, and astigmatism has been treated for up to 2.2 diopters. This is actually a 2-year follow-up. So with this background, we did a similar study in about 68 eyes, follow-up of about 2 to 3 years, and none of our patients are progressed and all are stable. The best thing is about like more than 50% of the patients, when you see here, gained 3 or more lines just with the spectacles, and more than 2 lines in 25% of the patients. And there is a constant like stabilization or the flattening effect, which has been persisted even after 3 years. So with this background, we would like to give certain recommendations in the management of progressive keratoconus, especially with the clear central cornea and ideally a central cone and expected corneal thickness. With our study, it was only 350 microns. Literature says it is 450, but even then we can consider up to 350 microns. We have a larger sample size and follow-up of about 3 years now. And optical zone, we usually interplay between 5.5 to 6.5 millimeter. That depends on your thickness, residual bed thickness, and target refraction. Even though we cannot correct complete ametropic correction, but we should never target for hyperopia. Thank you.
So, Doctor, very nice presentation. What basically we have been doing till now, we have never ablated more than 50 microns. And you are showing 80 microns, which is too much for a keratoconus patient, where you know that even after cross-linking, the cornea will shrink and they will lose the thickness.
True.
So what is the starting factor? Now, what do you think? Like, suppose, do you correct the sphere also? Because we are talking not only, we always tell the patients that it is not to remove your glasses, it is to make the cornea more smooth.
True.
To remove the, so how do you start the patient?
Ma'am, basically there is a fear in all our surgeons whether we should do up to 80 microns. That is one thing, and even it's there in ocular tumors also, surface tumors, whether we have to give topical therapy or we have to surgically excise. The same fear is there here also. We don't know whether it will progress or not. And what we found out, a weaker, thicker cornea is not going to help us. A thinner, stronger cornea is better than a weaker, thicker cornea. And all that we need is our follow-up results, which is like more than actually 4 years now, and none of them have progressed. And we do advise them systemic serum Ig level estimation and all, because most of these patients, they have eye rubbing. If you advise like modifiable factors in a patient, this is definitely going to help. And second question is like, do I treat spherical or cylinder? My priority is always to treat the cylinder, so they'll better accepted with the spectacles. Usually when you see keratoconus, they'll be like -8, -6 cylinder. Even though we cannot correct full, but we do up to like 4 to 5 cylinder can be corrected now.
And also the patient that you showed, the thickness at the starting was only 429 microns.
Yes.
Which to start with is very less.
Yeah.
And over that you ablated 80 microns. It is too dangerous, I would say. I don't know what other.
This was an index case actually. We tried, and after a proper counseling patient, explaining him the risk factor, and he was an intern, so he could understand the benefits also. And for our lucky thing, is not progress. He's doing very well actually. He has 6'9" now. The one thing about keratoconus patients, even in an advanced keratoconus patient, when they have two segments of eye cylinder, that itself acts as a pinhole for them.
Yes.
So when you actually see patients of keratoconus, sometimes they will reach 6'6",
yes,
but they do have like -6, -10 cylinder.
Yes, yes.
That's the thing.
And also, why are you using alcohol when you can go for the transepithelial PRK? I mean, or PTK mode.
When we see the like surface of the keratoconic cornea, it is not regular.
Yes.
So transepithelial, we might have to do epithelial mapping. We cannot ablate it properly. If I keep a 50 micron setting in transepithelial, it will ablate part of the stroma also, because especially over the cone, epithelium will be thinner,
yes,
and it's thicker in the periphery, so we cannot do that.
Okay, thank you. Any other? Sir, thank you so much.
Thank you.
You can play from the laptop.
Actually, this is
Dr. Rajan Gupta is there. The next, okay. So you are ready with your talk next. Yes, sir.
Good afternoon, everyone. So I'll be talking on management of perforated corneal ulcer. So we all know that it is an ophthalmic emergency and it has to be treated within 24 to 48 hours. So the first thing that you do when the patient comes to you is you immediately start all the medicines and counsel the patient party and the patient and shield the eye. That's the first thing to do. Why is it an emergency? So what is going to happen once the cornea perforates? So once it perforates, the first thing that you're going to see is there will be chances of hypotony, and there's high risk of microbial entry and chances of endophthalmitis, shallow AC and its problems like formation of peripheral anterior synechiae, disorganized anterior chamber, and long-term glaucoma. So the main principle is to support the globe, form and maintain the anterior chamber, heal the wound, prevent secondary infection, and address the cause. So the perforation can be traumatic or non-traumatic. In that, it could be infected or non-infected. So there are multiple causes for non-infected ulcer. And location, it could be central, mid-peripheral, or peripheral in location. So multiple modalities are being tried. So first one I'll be discussing is the tissue adhesives. So here we use the most commonly that we use is the cyanoacrylate glue. So I'll be discussing the cyanoacrylate and the fibrin glue as well. So cyanoacrylate, it acts based on polymerization mechanism, and the action starts within seconds, and the optimal action is at 2 minutes. So the benefits that it is bacteriostatic against gram-positive organisms, and it also disrupts the stromal melting. So it can be done on the slit lamp, or it can be taken under sterile conditions, that is in the OT. So the technique is whenever you see a perforated corneal ulcer, so if there is any slough, you will have to debride it. Once it is debrided, you have to debride 1 to 2 millimeters of the surrounding epithelium, or else the glue is not going to act. And then you have to place the minimum amount of glue. This is the key here you have to follow. And once that is done, you check for any leaks. Form the anterior chamber with air, and if there is leak, you can still use a little more glue. Okay, and once that is done, you can place the bandage contact lens and seal the wound. So there are other methods also being tried. You can also use a small piece of drape. You can put 1 drop of the glue, and then you can stick it over the perforation and then place a PCL. That's another method being tried. And the third method, if the perforation is of a little larger size, you can always use a scleral patch augmented with the cyanoacrylate glue. You can use the glue as well as the sutures. Also, a tuck-in scleral patch is also being tried along with the glue. So the main thing that you have to look for is you shouldn't overuse this glue. The moment you put too much of glue, it is going to form a mound, and the surface is going to be very irregular. So there will be a lot of problems. So what are the complications? So if it enters into the anterior chamber, there can be endothelial and lenticular toxicity, and raised IOP, and as I told, cataract formation, and also giant papillary conjunctivitis. So how long the glue should remain? So it can be there for weeks to months depending on the size of the perforation. So ideally we wait for it to spontaneously dislodge till the stromal scarring and vascularization has taken place. So coming to the fibrin glue. Fibrin glue here is biologic, it's biodegradable, less toxic, and it works only for small perforations. So here you should remember that fibrin glue is never used alone. It is used along with other modalities. The reason being it gives poor tectonic stability when used alone. So coming to amniotic membrane transplantation. So the benefit is here, it enhances scar formation, reduced vascularization, it has growth factors, and there's reduced risk of corneal melt. So coming to the technique, so it is done in different techniques. So one of the technique is where you use a filler, that is you use a multi-layered AMG. On that you place another layer of AMG with the basement membrane up, so that is a graft. And then you can also use a third layer of AMG, that is called as the patch. So here the basement membrane is down. So this is a multi-layered technique. And then you can augment it with the fibrin glue as well, and then place a BCL. And another method is called as the augmented AMT, where you use 5 to 7 layers of AMT and then fill that perforation. And then you can use another layer of AMT and then suture and augment it with the fibrin glue. And the main aim is you have to wait for it to scar. Once it incorporates into the cornea, it's gonna scar, and then you can place a keratoplasty in future if it's in the visual axis. Some studies have also been tried using the umbilical cord patch as well. Coming to the conjunctival flaps, here you use this method whenever there is a poor visual potential. So the most common thing that is being done is the advancement flap. So this the Gunderson's method is commonly being done. The only thing is there won't be any visual potential because already the vascularization would have taken place and the graft is not going to survive in these cases. Some studies have also been they have also tried making a pedicle flap from the conjunctiva. So it is said that it's much better than the Gunderson's. So that depends from case to case. And next, coming to the Tennant's patch. So you can also use a Tennant's patch. The benefit being it is autologous. There is no immune response, no tissue rejection, and you need not have to rely on a donor tissue or an eye bank. And it also gives you a successful keratoplasty in future. So again, you can harvest it from the patient's own cornea. So you just have to take a little bigger size of the Tennant's compared to that of the perforation, and then place it on the perforation, this spread it over, and once that is done, you can suture it, plug it, and you can use an amniotic membrane to seal it, and then you can place a BCL. It also works very well. Again, that gets incorporated into the corneal stroma, forms a scar, and then you can place a perform a keratoplasty in future if it's in the visual axis. Next, if you have access to tissue, then yes, you can use a corneal patch graft. Nothing like it. It restores globe integrity. It could be full thickness or lamellar based on the case. And if it is too small, you can always use a skin biopsy punch and perform it carefully. So, and if the infiltrate is too large with the huge perforation, and if you have access to eye bank, you can perform a therapeutic keratoplasty as well. And there are some cases where there will be large scleral melt. So even the keratoplasty, the corneal size won't be enough. So you can do something called as tectonic epikeratoplasty, where the corneal button itself as a whole is being placed, and it kind of provides a good globe integrity. It is not going to give any visual potential to the patient. Also, smile lenticules have been tried to seal the perforation. Again, it depends on the size of the perforation. You can augment it with the glue. And in case of, just 1 minute, just in peripheral perforations, whenever it is there, so you can always design it based on the size and the shape of the perforation and measure it, and then you can do a peritomy there, and you can design the size of the donor graft. It is called as a stencil method, and then you can place a graft. So that depends on the size and shape of the perforation. So to conclude, this thing, it's an ocular emergency and timely management is the key. So you have to avoid perforation whenever you can, but if it is perforated, your main aim is to restore the integrity and prevent infection. Visual rehabilitation is done only in the second sitting. Thank you.
Yeah, thank you, Dr. Aparna. It would have been better if you had used real patient images instead of using animation.
Right.
This is All India conference that you are coming.
Right.
So animation any one of us can see.
Correct.
So one thing is, where you said that fibrin glue, where do you use fibrin glue for perforations? What size and how do you use it?
Very small perforations, less than 1 to 2, like around 1 to 2 mm or smaller than that. We do not use it alone. And if there is a lamellar tear or something, we can use it for those as well.
Not so much. Cyanoacrylate glue is always better.
Yes.
Less than 2 millimeters, more than 2 millimeters, nothing will work.
Yes.
But less than, and if you are using amniotic membrane, as you showed in the diagram, So there, where you are using inlay and overlay, there maybe fibrin glue can be used. Otherwise, not much role is there. Dr. Shiv.
Which brand of glue would you recommend to the audience?
We use acrylate actually.
Yes.
No. That is for the cyanoacrylate. I was asking for the fibrin glue.
The one that we use, that Baxter.
Yes.
Yes,
Yeah.
that's the best. But then there's the cost factor. So we have a cheaper alternative. And for these purposes, I think the cheaper one is also good enough. Reliseal is also good enough. One more question. You said that you suture the amniotic membrane and then you augment it with glue.
Yeah. You use the glue first, and if needed, if it doesn't stay, only then you augment, put sutures only if needed,
Yes,
not in
that
all
was-
cases.
That was what I was trying to say, that you put the glue first, and most of the cases when you put glue, I don't think it requires suture.
Yeah, but if, as she said, that if it
If
is
it
not
doesn't,
stable, we can.
then you can use.
you can use
Just
3 or 4.
Yes.
Yes, not that you put suture and
No,
then
not
you
in all cases.
Yeah.
No. When you are putting suture, not in all cases you need to augment them with glue. It is when you are using glue, you really don't need sutures in majority of the cases. But if you are in doubt, then only you should put the suture.
Right.
Otherwise, glue alone works very good with amniotic
What she is
membrane.
trying to say is you can create an epithelial defect on the normal cornea. You can put fibrin glue, and the final part of the amniotic will stick with the fibrin glue. Over that, you can use a bandage contact lens. Their sutures may not be needed. If you are using anyway the sutures, then you don't need to use such an expensive fibrin glue. It's
You
very,
are
very
adding the cost, no?
Yeah.
Ma'am already
yeah,
said.
the same thing. So the cost factor in a normal person to pay 10,000, 11,000 worth fibrin glue, you have to even think of that. Okay.
Yeah.
Thank you so much.
Nice animations.
Yeah. So next we have Dr. Kavita Rao, as she has to go for some other presentation. So she will be speaking on optimizing cataract surgery outcomes in an abnormal cornea. Yeah.
Thank you very much. And it's a privilege to be talking in this session. I'll be covering a few broad topics which I think all of us as ophthalmologists, not necessarily only cornea surgeons, will deal with. So when you have, I apologize for the entire slide not being seen. When you are dealing with corneal ectasia with cataract, I think there are 3 categories of patients where we would deal with, where you're doing only cataract surgery, or if you're combining the cataract surgery, and if a keratoplasty is already done, then you're doing cataract surgery later. So,
Just rearrange this.
how?
Just play again.
Play again. Yeah, it's better. So if you're doing cataract surgery alone, then which cases, like, a patient comes with keratoconus, in which cases you're not going to be addressing the keratoconus. Obviously, if it's an older patient, because naturally the keratoconus has become stable, or if it's a younger patient and you've done the cross-linking, if the patient has undergone, is a happy contact lens user, if keratoplasty is not needed or is basically unwilling. Now, how do you decide the IOL? Are we going to use toric IOL in all our keratoconus patients? So you have to look at the topography, and if you have the EKR, then look at the EKR. The distribution of the keratometry needs to be more or less in the, like in a closed zone. If it is very well spread out like this, then I think it's best you go ahead with a monofocal IOL in these patients. And if it's a cross-linking, then minimum you need to wait for 6 months after you've cross-linked a patient, ideally preferably a year. This is a patient with allergy, with progressive keratoconus, with posterior subcapsular cataract, because having used steroids, so underwent cross-linking both eyes, and after 6 months I've planned the cataract surgery. Now, cataract surgery in toric IOL, when you're using, you can use any of the techniques which have been described. Either you can use manual marking or you can use the image guided system. Just one point I wanted to see, if you see the left hand video on the lower bottom side, I'll play it again. Once you're doing hydrating the wound at the end of surgery, you need to be careful that you don't overinflate. You can see that the toric IOL just rotates like that. And so you need to be mindful of that. And also, if you feel like, there is a high myopia associated, then it's also been reported that you can put in a CTR. So when are you doing keratoplasty first and then cataract surgery, then how do you deal with it? So obviously, once you've done keratoplasty, you need to remove all the sutures. Then suture removal will take about a year. And after that, 3 months after that, when the topography stays stable, only then you go ahead with a cataract surgery. This was one such patient who has a fairly regular astigmatism. You have to make sure you're protecting the endothelium, because in these cases already it's a donor cornea which is there. So the rest of the surgery is pretty much similar. You have to make sure your entry is not at the graft host junction. You're entering outside of the graft host junction, and then you can go ahead with using a toric IOL. These are very grateful and happy patients at the end of surgery. This was how it looks when you're doing the suture removal, because you're not removing all of it at one go, and eventually you will end up getting a good patient. Now, this is another patient who came with this hydrops in his graft. And ideally he was an older patient, so I should have done a combined surgery, but the other eye also had advanced keratoconus. It was very difficult to get a reading. So I convinced him to first do a keratoplasty, then all sutures out, and eventually I did a cataract surgery. So, it's not a mindset that yes, he's come with a fully opaque graft, so you have to do a combined, because it's difficult. But of course, in some cases you can't help it. You have to go ahead with doing a combined surgery. Now, DALC also, the patients who develop cataract first do DALCs, then do all the sutures should be out, and at the end of it you go ahead with the cataract surgery. Now, when you're combining, what's the problem? Obviously, problems are that in DALC, when you're combining with cataract surgery, there is an issue of the desmids perforating, but you can dissect to the mid stroma and then go ahead with the rest of the surgery. Obviously, when you're doing an open sky surgery like in triple, it's very difficult to get a rhexis, like I'm showing here. So the technique to beat that is that when you have such cases, first you do a closed chamber phaco, as I'm doing here, and then you go ahead with doing a triple. So because this patient had a central scar, we then went ahead with doing a triple surgery, and patient has done very well. Now, corneal scars, I think when you're having corneal scars with cataract surgery, it all depends on what the location is, thickness is. If it's denser, obviously you have to be a combined case. Now, this was a patient with spheroidal degeneration and who had been advised of triple surgery elsewhere. We thought, let's just see, how he does. So we first finished the cataract surgery, and at the end of it, I just debrided or did a superficial keratectomy and then put in an amniotic membrane at the end of surgery. And this was how he looked at the end of 1 month. And this was at the end of, I think, 3 months. And then this was, we did PTK. You can see there's still some central haze. And so you have to probably have a staged management in these patients. And of course, if it's such a dense scar, then there's no option but to go ahead and do a triple cataract surgery. Now, this I've already shown. If a patient comes with a failed graft, then you can use an endo illuminator and do it phase-wise, where you're first doing the cataract surgery, and then you're going ahead with, doing the, changing your corneal button. So open sky is a complete no-no, and there's really no excuse for doing an open sky keratoplasty in this day and age. So the other case, I think, which is relevant for us as all of general ophthalmologists also, if you have a pterygium with cataract surgery, so ideally it's best to do the pterygium surgery first and then go ahead and address the cataract, especially but if you are doing a premium IOL, if it's a large pterygium, it's covering the visual axis, irregular astigmatism. In some cases, maybe you could do it combined, especially if the patient also is not willing for a double surgery. So if you're doing it a combined surgery, I heard some discussion about glue out here, and I feel that in my hands, I have no financial interest, unfortunately, but somehow the Reliseal, unless the cold chain is maintained very well, it does not work well in my hand. I use the Baxter glue and it gives wonderful results. So, and another tip is when you're excising the pterygium, go as close to the limbus. Don't go much further away, because anyways, you can see the conjunctiva, it kind of pulls back and retracts. So you don't want to unnecessarily end up excising tissue which is not pathological, and you can always go back and excise more from there if you feel that still got the pathological tissue. So as you can see, I'm inserting glue there in the end, and the graft stays beautifully. I know a lot of people use the blood of the patient itself, but I don't know, I have no experience with that. So, and these patients, of course, even though it's being done topical, I make sure that the patch stays on for 24 hours, because I'm always fearful of the graft dislocating because of eye rubbing. In 24 hours, it's quite well fixed. So, another thing is about cataract surgery. If you're doing combined, if the patient has a cataract and corneal trauma, then you have to. So, I think I'll just end because. So these are just videos where I'm showing that why we are combining. Otherwise, like I said, if you have a corneal tear, you have to first suture the corneal tear, remove sutures, and then address the cataract. So in this case, because this patient had a graft dehiscence, she was staying out of Mumbai. We planned both at the same time, and also the other case had a combined VR surgery. So that's it. Thank you so much.
Thank you.
Thank you.
A very good presentation. Very good videos. I think this is the way we should do it. And as we all know, Baxter is definitely better. Yes. And regarding pterygium, if the size of pterygium is very small, like say 2 millimeters, 2 to 2.5, not causing any problem, you are getting good K1, K2 readings.
Yes.
So you won't prefer phaco with pterygium?
Yes, ma'am. That's what I said. If it's smaller, then I definitely do a combined case.
Yes.
And if already on topography it's not showing any astigmatism, yes. But sometimes, if there is you're planning a toric IOL multifocal, I would still probably.
So these patients won't be for toric then, if you are doing a combined surgery.
Correct.
So what will be the step very important in biometry that you will consider? What is your target refraction in these cases? What happens when you do pterygium and cataract together?
If if the astigmatism pre-op is more than 0.75, it's more than 1 diopter, then I would definitely prefer to do a phasic surgery and wait for at least a month. I know in private practice it's very difficult to say 3 months, and it's easy for me to say wait for 3 months because, we had this discussion in other forum where, the audience said, no, my patient will run away. But yes. I would say at least 1 month you have to wait.
I'm talking what happens is when the pterygium causes the flattening of the cornea. So what happens, it's well reported that if you do pterygium and phaco together and you all aim for 0.5 there is always a myopic shift.
Correct.
In your final.
Correct.
So what I would like to have from you, answer from you is that you should always target zero power.
Zero. Right.
Never keep it myopia, because it will naturally, the cornea will, when the flattening of the cornea is not there, when you removing the pterygium, then the cornea will become steep. So the patient will anyway go for myopia. Lot of studies are there.
Correct.
In that.
Yes, ma'am, I agree. Thank you, ma'am.
Thank you.
And one point I would like to add regarding this cataract with pterygium. It is not only the length of the pterygium which decides the astigmatism. There are many more factors.
Correct.
So one thing we choose is the length of an astigmatism, and second is there's difference in the KVKH of more than 2 diopters.
Correct.
I think it's 2 diopter, not 0.75.
Yeah. Yes, ma'am. I would definitely take your opinion also. But in my practice,
I would like to have the discussion if you have some other opinion.
Ma'am, I would say let's have a middle point and say 1 diopter, because 2 is definitely pretty large.
Hard.
Then if you're saying everything less than 2, we can go for combined. Then probably it's better to then plan a monofocal IOL, because in case you're wanting to address that astigmatism, because nowadays even 0.75 1 diopters we are
this
addressing.
we were discussing for sequential surgeries only, na?
Correct.
Simultaneous surgeries.
Yeah, that's what. If it is around 2
diopters, if it is sequential,
if it's 1.5 diopters, you're saying we can go ahead with simultaneous
keratometry.
Yes, but if it's 1.5, then we can do simultaneous. Is that what you're saying? No.
Yes, you can do.
You can.
Depends upon the
patient.
If the patient says, I don't want to come back, gaon se aaya hai, and they want both the things, and you can give him what best you can give, and they don't mind wearing a bit of glasses. So -2 tak we have done lots.
Yes,
so
yes, I put
results.
that logistically. If the patient is not willing, then patient is the king.
Yes.
But ideally, if it's 1.5, then I would want to do it, sequential. But agree, ma'am.
Thank you.
If it is double-ended, then definitely you have to be.
Yes, yes, sir.
It's a sequential procedure. That's all.
Yes.
And in case of scar cornea, which keratometry, KRD, how you prefer? Suppose it's scar cornea.
Yes.
So what is the standard procedure you can prefer for the keratometry?
If it's very dense, then obviously, like I showed the second case, you are going ahead with. I went ahead with doing a triple surgery. But in the first case where I did an amniotic membranal, I just used the keratometry from the other eye.
That is axial length of that eye. That is standard procedure. What do you prefer the cornea person? Axial length of that eye.
Correct.
And the K1, K2 of the other. If it is very curved one.
Correct.
Or otherwise very small curve, preferable. What I prefer, that is you can do the topo K. Or
Correct.
same K we can do the prefer. If you have that facilities of your pentacam or scan, so you can prefer the same K or topo K. that are much more precise if you have the scar is more smaller. If it is very much dense case, definitely that is the only procedure we have to, and it's given unpredictable result also.
Yes, sir.
Yeah.
Thank you, sir. Thank you, ma'am, for letting me present earlier. Thank you.
It's a wonderful talk by Dr. Kavita. After Dr. Kavita, we'll call the Dr. Ranjan Gupta. Yes, sir. So he will deliver the laser vision correction in borderline corneas. Over to you, Dr. Ranjan Gupta. Yeah, please.
Hello. Yeah, slide. Can you start the slideshow? Good afternoon, dear friends. First of all, I would like to thank AIOS for giving the opportunity to me to express my views on the topo-guided LASIK, which is my approach to the laser vision correction in the borderline corneas. So whenever a patient of refractive surgery walks into your clinic, the various selection criteria are: we can treat by PRK, myopia up to -5 diopter spherical equivalent, and hyperopia of +2.5 diopter or spherical equivalent, and astigmatism can be treated up to 2.5 diopter of the cylinder. And by the LASIK, we can treat up to -8 diopter of myopia, and in hyperopic patients we can treat up to +4 diopters. And in astigmatic patients, we can treat up to 4 diopter cylinder of myopia. What are the various limitations for the laser vision correction? The central corneal thickness should be more than 470 microns for PRK patients, and it should be more than 490 microns for the LASIK patients. The residual stromal thickness should be more than 400 microns for PRK with API on, and should be more than 300 microns for the LASIK patients. And the refractive error should be between -8 diopter spherical up to +4 diopter spherical, and the percentage tissue alteration should be less than 40%. That is the PTA is the total corneal thickness minus the flap thickness and minus the stromal tissue ablated, and the keratometry reading should be between 39 diopters to 48 diopters. So go for an example. It's a female 24 years of age which has a manifest refraction of -2 diopters spherical, -6 diopters spherical with -2 diopter cylinder at 180 degree, and the mean keratometry is 42.71 diopters. The pachymetry is 500 micron, and the flap thickness, I will go for a 90 micron flap. So it's a borderline cornea, but I can do it. How? First of all, which procedure to choose among the LASIK or the PRK? I'll go for the LASIK in this patient. I'll go for choose a thin flap and will do a LASIK or a topo-guided LASIK over PRK. But why not PRK? Because of the post-operative pain and the late visual recovery and the risk of phase in higher refractive errors. So should I go for a standard LASIK or topo-guided LASIK? So important things to notice for this: the residual stromal thickness after 90 micron flap should be more than 300 microns, and patient should have a normal topography. And the standard treatment offers, that is the basis of the standard treatment, are based on the keratometry readings, the pachymetry values, and the refractive prescription of the patient. It corrects the sphere and cylindrical component of the refraction only, and it's a good option for the patients having the normal topography. So the topo line, that is a topo guided treatment. This is a new technology which has the unique capabilities that provide surgeons a greater degree of individual customization, and this procedure is redefining the quality of vision, proving that the many patients experience better vision than ever they did with glasses or the contact lenses. So the topo-guided treatment offers us a basket of choices. You can go for a topo-guided LASIK, which corrects the refractive error based on the topography of the cornea and centers the ablation profile on the visual axis for better visual quality and maintains the asphericity of the cornea along with the reduced depth of ablation. And in the topo smoothing procedure, you can do the anterior corneal surface smoothing with or without refractive error correction. So the topo-guided LASIK, the principal elements are the assessment of the topography and centering the ablation on the visual axis. It's a topo-guided platform is provided by Zeiss. It has an Atlas corneal topographer with the CRS master software, and you can use MEL 80 or MEL 90 excimer laser for this. So on the corneal topography, the patient eye is imaged and analyzed using unique elevation points on the cornea. So the topo-guided planner, that is the CRS master, the Atlas data is sent to the CRS master to create a customized ablation profile, which allows the combination of standard and topo-guided treatments. The preview on the CRS master, that is the planning station, you can see a orange cross which represents the pupillary center, and it determines the center of the optical zone and represents the anatomical center of the eye. And green cross, it is on the corneal apex position. It is close to the visual axis and it corresponds to the manifest refraction. The pupil to ring center distance represents the topographically derived angle kappa. In the treatment planning, we import the topography to the CRS master, enter the various treatment parameters, that is the manifest refraction, target refraction, the optical zone, and procedure selection, that is LASIK or PRK, the flap parameters, the treatment mode, and the keratometry readings, which are directly imported from the topographer. So we can, again, the same female, -6 diopter spherical with -2 diopter cylinder, and the pachymetry is 500 micron. You can see the treatment planning on the CRS master between standard versus topo-guided. See the residual stromal thickness after standard treatment is 273 microns, and after topo-guided treatment it is a residual stromal thickness 302 microns. The patient which looked impossible for the LASIK surgery, we can go ahead with the LASIK surgery in this patient. So the ablation principle is the ablation starts from the highest point of the irregularity in topo-guided treatments. And the important things to notice for this topo-guided treatment is the perfect topography measurement is a precondition for successful topo-guided laser treatments, and inaccurate or unreliable data from topography will lead to an inaccurate treatment of the patient. And the laser automatically adjusts the laser pulses to match topo-guided treatment. And so else, what can we do with topo-guided treatments? We can treat the corneal irregularities, the optical zone enlargements, and the decentered ablations, the flap complications, the corneal haze, and the irregular astigmatism of the patient. So the various indications for the topo-guided topography smoothing planning is eyes that cannot be well corrected with glasses or the contact lenses and have irregularities on the corneal surface with inconsistent refraction. And the ablation profile is based on the topography map only. It's a two-step approach. Initially, you create a regular cornea. Later, we correct the refraction with standard treatment, which provides us a higher safety and predictability of the patient. So the customization by the topo-guided planning, it offers us a tissue-saving solution. The clearly reduced depth of the ablation is a major benefit, in particular also for the secondary treatments for these patients. So it is a leap forward. The proven clinical experience show improvement in uncorrected visual acuity with best corrected visual acuity with the excellent visual acuity outcomes. The clinical results indicate statistically significant improvement in contrast sensitivity and the improved control of lower order aberrations and corrects the topographical irregularities. So to summarize, topo-guided LASIK, it corrects the refractive error based on the topography, ablation on the visual axis for better visual quality, and maintains the asphericity of the cornea with a reduced depth of ablation, and smoothing of anterior corneal surface with or without refractive error correction. And for the secondary treatments for decentered ablations, small optical zones, central islands, flap complication, corneal haze, and the irregular astigmatism. Thank you.
Very good talk. Self-explanatory. In detail you have spoken. Excellent. So how long you tell the patient if you have to do a topo-guided treatment to stop the contact lenses?
Just 1 week before. If the patient is using generally soft contact lenses.
Okay. So anything?
Do you have any financial interest for these?
No financial interest. I'm doing on its own. No financial interest with Zeiss.
Okay.
My talk is not sponsored by Zeiss.
Yeah. So different, just for the other people, different machines have different platforms to map the corneas. Zeiss has CRS
CRS master software is there.
Yeah. So for Alcon, they have Topolizer.
The Contura, the
Contura, yeah, Topolizer, what they say.
Yes,
Contura.
but ablation profile, I think different is.
Yeah, so all the machines are good as long as you see your pocket and you understand the how to adjust the parameters, the optical size. He spoke very fast, but he has covered everything in detail, every point.
Thank you.
Yeah. Thank you.
One more question I would like to ask, that these platforms have come recently. Earlier we had different topography machines and different laser machines. So what actual difference in terms of accuracy could you get with these platforms? I mean, earlier we used a different set for laser machines.
Yeah. So earlier, basically, what she says is that we used to do the total aberrations of the eye. Now again,
that was based on the aberrometry.
Aberrometer, total aberrations.
Basically, that aberrometer picks up the total aberration of the eye, and we basically later on there is a change in the lenticular aberrations, and we are treating these lenticular aberrations on the cornea.
Yes.
So when there is a change in the lenticular aberration and the visual quality deteriorates, that's why the concept of the topo-guide LASIK has come.
Yes.
Rather than that the C LASIK, the customized LASIK.
Yes.
Okay. Thank you.
Yes.
Yeah.
Can you give him mic? Can you please give him mic? He's bringing.
So the attention has again gone to the topo-guided treatment instead of the total aberrations.
Yeah, definitely, ma'am, because whenever there is change in the lenticular aberration later on in the later life, so the quality of vision will deteriorate in these patients. But the earlier treated with the customized LASIK, when we treated the lenticular aberration in the cornea,
yes.
Why to make it different?
Yeah. No, it will give you the post LASIK, the image quality of the image much more better. And that's why the most of the time patient achieve one mind, whatever the patient had the vision before the LASIK with the best corrective visual acuity. Most of the you can see the patient read a one line more. Suppose the patient having the 6/9 or something, whatever we explain pre-operatively, you will see the whatever that you see in the glasses. So it is found, it is my personal observation that when it is customized or it is a topo guided, patient will achieve one line more. He can read the 6/6.
Just make a point that we've been doing a lot of this with Schwind Amaris. It has come with the Keratron Scout, and it's a very different platform to work with. Very robust. Results have been amazing actually. But it's not that every treatment you have to go towards topo guided treatment. Very important to tailor that out because sometimes we feel that topo guided is great, but it's not that every time you have to go for a topo guided treatment. Sometimes you get better results with the conventional wavefront guided treatments basically. So it's important to understand how your machine interprets the topo. And just another additional point which I also wanted to make was not all topo guided treatments gives you a lesser amount of ablation. It will also depend upon the type of topography that needs to be eliminated. So if you have a peripheral skirt wherein the peripheral skirt is a little more steeper, then those patients will actually require more amount of ablation in that zone. So therefore you will tend to identify some patients where the topo guided ablation gives you actually more ablation than the conventional. So it's important to just
note
there
is a difference in the machine. Basically that is the software which is providing the lesser tissue ablation. In particular in the CRS master planning it is there. I'm not planning anything, but it's a machine which tells because in Contura, in the Alcon, the ablation is more for the topo-guided treatments.
Exactly.
And out of hardly 10 patients, one patient will need topo-guided treatment if there is any surface irregularity in the cornea.
Great.
If the cornea is regular, that doesn't need any topo-guided treatment. That is overhyped thing. We are treating overhyping that topo-guided treatments.
Perfect point.
Yeah,
Thank you.
And there are few wavefront analyzers. We can divide the cornea. We can separate corneal operations from lenticular operations. Those cases works very well.
Thank you, sir.
Especially Schwind that has technology.
Thanks.
Thank you, sir. Thanks for the nice talk, wonderful talk. We'll move on to the next speaker. We will have the next talk by Dr. Rakhi Kushumesh, and she will deliver the talk, Grafts and Glues in Ocular Disorder. Over to you, Dr. Raki Kusumesh.
Yeah, good afternoon, everyone. My topic is actually graft and glues in ocular disorder, but no, this is since this topic is very large and cannot be covered in a 7 minutes, so I would limit my talk to role of graft and glues in restoring ocular integrity. So the most common corneal emergency what we face is corneal perforation or impending perforation or desmatoseals. So first objective that we should look at is to restore the globe integrity in these cases, and there are several management present for managing these corneal emergency cases like suturing to adhesives, amniotic membrane, Tenon's patch, corneal transplantation, and other different types of grafts. Majority of my cases were done in COVID pandemic. So coming to glues first, there are two type of glues available, like synthetic and biological. Synthetic one is easily available and it is very less expensive and easy to use, but it has a high tensile strength and it is not biodegradable. So it has to be used for external surfaces only, not for the intraocular purposes, and the most common indication is corneal perforation. On the contrary, biological glues are expensive, they require reconstitution, and they are of low tensile strength, so they cannot be used as sealant, rather it has to be used as adhesive in all the cases, and it is biodegradable, and the most common indication like an amniotic membrane or others. So this is the way how we prepare the cyanoacrylate glue. It has to be just, we need to load, while in fibrin glue we have to reconstitute the fibrin and thrombin. Now we don't have that thermostat for the preparation of glues. So there are several techniques available for application of cyanoacrylate. Now my preferred technique is to use the back handle of Marocel sponge, which gives a very thin and fine layer of glue over the operating sides. So these are a few videos. So like one is the fungi, dementatious fungi, where we are taking biopsy in the same sitting, as well as putting the glue in the weaker side as well as at the site of perforation. Second one is in the vitrectomized eyes where the cornea fistula was there. So we have to deepithelize the tract completely before applying the glue. So just I'm sharing few tips for corneal gluing. One is to always remove the necrotic tissue and mucus before application, and deepithelize the surrounding area as well as the site of perforation. Dry the surface completely before application and apply only a thin layer of glue. Don't heap the glue over there. And check the glue before applying BCL. Sometimes BCL is stuck with the glue. Second one is amniotic membrane graft. This is one thing that we cannot think of any ocular reconstructive surgery or any ocular surface surgery without this membrane. This is a biological membrane which has no immunogenicity, and it has both mechanical and physiological barrier. It has several properties like epithelization, anti-angiogenic, anti-inflammatory, and antimicrobial. So there are various techniques available for AMG application. One is the graft or inlay technique. It is used where the tissue loss is present because it actually replaces the volume loss. And second one is the patch or overlay technique, where the epithelial lining is downwards and it acts as a biological contact lens. And the third one is layered or filling technique, where both the overlay and inlay used. So it all depends upon the size of perforation or impending perforation for the technique. So here I am sharing one case. This is a case of perforated PUK, and in this multi-layered amniotic membrane was applied, and it was secured with the cyanoacrylate as well as the sutures. So after 3 months, patient had good strength in the periphery. All reaction were under control, and here you can see in ASOCT there was a good thickness of amniotic membrane after 3 months. So now this patient is waiting for optical PK. I think it has been done because of steep cornea and high astigmatism. So this is a second case. He has a case. He was under tuberculosis treatment. He was taking ATT, and he had a rapid this necrolysis of the cornea and the periphery. And so we did amniotic membrane grafting in this case, and that gives a very good sealing at that part. And ASOCT also showed a good result in this. So another application, like in cases of SGS, where we need to do take care of perforation, sterile perforation in these cases, and sometimes in infective keratitis, basically in the viral keratitis, not for other suppurative keratitis. So AMG is a safer method to restore ocular integrity in perforation or impending perforation, particularly in cases where the donor cornea is not readily available. Then the Tenon's patch graft, I would say this graft was savior in COVID pandemic, and it has many advantages, like it is autologous and there are less chances of autoimmune reaction, and it is economically very viable option. Disadvantages, it doesn't give any kind of vision improvement because it's an opaque tissue and it has a low tensile strength. So this was a case of a 43-year-old man who came to us in COVID, and he had recurrent episodes of stromal viral keratitis, and he had a big perforation at that time. So we didn't have cornea, and for tissue adhesive, it was very large with iris prolapse, and amniotic membrane was not available to us. So we planned for Tenon's patch graft, and after patch graft in 3 weeks, the graft vascularized and epithelialized. Then we removed the suture, and then afterwards, when cornea became available to us, we did optical PK as well. So harvesting a Tenon's graft can be harvested very easily from the superior nasal or superior temporal quadrant, and it can be secured with the fibrin glue because it's a very sticky tissue. To better apply 1 drop of glue and then put the Tenon's graft, and it can be secured with overlay sutures. And suture removal is also very easy in these cases, usually after complete epithelialization and vascularization of the graft. So there are few modifications are also documented in the literature with Tenon's patch graft. Here we publish a report in IGO. This was the original article. Apart from seeing the efficacy, we also looked at the predictors for successful outcome, and we found that desmatoseals gives good result in comparison to perforation, non-infective, better than infective. And among infective keratitis, viral keratitis were the good cases who gave good results, and paracentral and peripheral perforation we found better results. Last, this is a patch graft when you have cornea and you have to.
Can you just yeah.
Okay, thank you. We have to do multiple procedure at same time, then better to go for corneal transplantation. So this is a flow chart. This is how I manage my cases. If the patient comes with corneal perforation with no tissue loss, corneal suturing should be done. If patient comes with tissue loss and if the perforation is less than 2 or less than 3 without any incarcerated uveal tissue, then cyanoacrylate glue is best. And if there is incarcerated uveal tissue, you can go for Tenon's patch graft or amniotic patch graft. And if the perforation size is more than 3 and donor cornea is available, better to go for patch graft in the peripheral lesion or tectonic PK for the central lesions. And if it is not available, then up to 6 or 5, we can go for the Tenon's patch graft or amniotic with or without cyanoacrylate glue. Thank you so much.
Thank you. A very nice collection of videos and photographs. Nice presentation. Thank you.
Thank you so much.
So we have already discussed your topic in detail.
Yeah, exactly.
Thank you. Thank you so much.
Thank you, ma'am. Thanks for the wonderful talk. We'll move on to our next speaker. We have with us Dr. Pooja Rai. So Dr. Pooja will deliver the talk, Current Practice in Dry Eye Disease Management. Over to you, Dr. Pooja.
By meantime, Rakhi told using of the other side of the vexel sponge. That is a very good point. But once you touch the glue once, and you need to touch one more thing, then only the glue will come very in thin manner. You need to touch actually one more time extra. So once you dip into the glue, then touch beside of that one with where you don't have a glue, then touch on the cornea. Then it will give a very nice thin film. That's what we practice. By the way, nice presentation.
Good afternoon, everyone. I thank AIOS for this opportunity. Today, I'll be talking about current practices in dry eye management. Specifically, I will be mentioning what we all can do in our own clinics, so that because COVID pandemic has given us a lot of patients coming with dryness, and it is no more specific to IT professionals. Now, even children and old patients are coming with similar complaints. So by the end of this talk, my aim is that we have a summary of what we can do in our clinic to even without in the hi-fi instruments, and then how we can treat these patients. I have no financial interests in any of the products which I mentioned. So why the problem? The problem is because of the pandemic, that we all are, not we all, but everyone else is working from home and using the system a lot. And now they claim that in India, it is estimated that 60% of Indian urban population will be affected with dry eye disease by the year of 2030. And this is not a small problem, because we are prescribing medicines to the patients, and it is a big economic load for the patient. And apart from that, intermittent blurring, burning, all this is affecting their effectivity in their work. So it is to be taken seriously. But when they come to us, we just cannot give them lubricants and send them off. So we should know what are we going to treat. The aqueous layers, as we know the basics, but still each one of this has to be treated in a different manner. Now what we see is, initially we'll start with the lipid layer, examination of the meibomian gland function, what all we can do in our clinics. So nowadays there are studies saying that we can quantify and we can give the quality, we can grade the quality of the meibum which is secreted from the meibomian glands. So the grade 0 is when there is clear meibum coming out of the glands. Grade 1 is cloudy fluid. Grade 2 is cloudy but particulate. And grade 3 is toothpaste-like secretions, which is very commonly seen nowadays in our clinics. And then the expressibility. The expressibility is seen from the central part of the lower lid, and we normally take the central 5 openings of the meibomian gland. And then grade 0 is when all of them are well expressed. Grade 1 is when only central 3 or 4 glands openings are expressed. Grade 2 is 1 or 2 of them express, and grade 3 is none of them. That means all of them are blocked. Third is the meibography. Meibography, nowadays we have machines which give us meibography, but traditionally we can also, if suppose we don't have a machine in our setting, we can use the autorefractometer, which has infrared light, and we can turn the lid and see how many glands are present and what is the structure of these glands. So autorefractometer also can be used, and we need not depend on these machines. So meibography is giving us a meibo score, wherein grade 0 is there is no gland loss. We can see in the first picture and also one thing to mention here is we also see the upper lid, not only the lower lid. Both the lids have to be everted and seen. So grade 0 is there is no gland loss. Grade 1 is up to 33% of gland loss. Grade 2 is up to 66%, and more than that is grade 4. Now why these theoretical grading is important? Because dry eye patients are not one-time patients. They are going to come to us every few months. So we need to note this in our notes and then follow up with this as reference as to the treatment is working or not. We will also know whether the patient is compliant or not. Okay, so we need to grade these in our regular practice so that it helps our management in the patients. Second thing is the tear breakup time. We are already aware of the fluorescein breakup time. Nowadays, we have the non-invasive breakup time, wherein it calculates the time between a complete blink and then after that, when is the first dry spot appearing on the cornea. So this is nothing different from what we do in the on the slit lamp with fluorescein this thing, but then it is all, this one is more repeatable because it is done by a machine. And any of the tests which I will be talking about now onwards, or even the previous ones, it is always better, and it is advised in most of the studies that we take at least 3 readings and then take an average of them, because any one reading is never repeatable. Even in the with the same observer, this may not be repeatable. So here we see a NIBUT where okay, my cursor is not seen there. So that green map is the topography of the tear film, wherein the yellow and the red patches are the dry spots which have appeared, and the written content at the side, it will tell us how many seconds it took for the first spot to appear. And the fluorescein breakup time, we all are doing this since ages. One point I would like to add in this is, I never cared about what medicine or what drops I am using to wet the fluorescein strip. But if we use proparacaine, then it disturbs the tear film layer. And if we use a lubricant, it will make it better. So our reading will be faulty here. So one of the cornea meets which I have attended, they have suggested that we use a preservative-free moxifloxacin eye drops, which will not affect the layer, and we get reliable readings here. And therefore, we also take 3 readings and then take an average. This was about meibomian gland dysfunction, which we can do in our clinics without anything. We can do with whatever is easily available. Now we see the lacrimal gland dysfunction, wherein we all know about Schummer's test, but still I will touch upon it. Second is the tear meniscometry, and the third is the direct assessment of tear secretion. Now this was something new which I got while making this presentation. I'll talk about it. Now coming to Schummer's test, all this traditional teaching is there that Schummer's one is reflex plus basal. That means we are doing it with so
we have lot of doctors to go, so you have to finish in 1 minute. Finish it off.
Okay, so this one is a direct assessment of tear secretion, wherein we are elevating the upper lid, the lateral part of the upper lid, and we can see the arrows are showing the openings of the palpebral gland of the palpebral lobe of the lacrimal gland. This is in short about the treatment, that is the tear substitutes, but it is not always about lubrication. We have to take care of the inflammation of the surface. Therefore, we have some anti-inflammatory drugs. Steroids are there. We use it as first-hand drugs, but then we cannot use it for long, and therefore cyclosporin and tacrolimus comes to aid when we have to withdraw steroids. And there are some secretagogues, but all these are under studies nowadays. And also in severe cases, we can give autologous serum, scleral contact lenses, and punctal occlusions. MGD treatment, lifestyle changes, gland expression, we can do in the clinic itself. Light and heat therapy, which is IPL and LipiFlow nowadays, and some medications. I will just wrap this. So as a take home, we can just sum it up in this. So what is the sequence of things which we can do? If we do Schummer's, first our TBUT will be affected, or vice versa. So first is we take a good history. We have some questionnaires like OSTI questionnaire. Second is we see the tear meniscus height on the slit lamp, and then we go for fluorescein staining of the cornea and conjunctiva. For conjunctiva, I would recommend not to do fluorescein. Sorry. not to do fluorescein. We have the rose bengal, which is much better for conjunctival staining. Then we do the Sherman's test. Next, we will see the lid features and the mebum expressibility and quality. After that, check for the meibomian dropout, wherein we have to evert the lids. We do not touch the lids until we do Sherman's, TBAT, and all the other examinations. And then last is the palpebral lobe of the lacrimal gland. Thank you.
Very, very good talk, and
I had a lot to talk.
Yeah, so it would have been very nice had we had more time. Yeah. So one thing to ask: do you use this check the osmolarity?
No, ma'am. In our practice, we are not doing it right now, and therefore I did not mention much about it. Yeah. And most of us may not be able to do it in our setups. So my aim was to do to prepare a talk for all of us, which we can do as the patient number is increasing day by day.
Right. Thank you so much.
Thank you.
Thank you, ma'am. Thanks for the wonderful talk. Then we move to our next speaker, Dr. Vishal Arora. So he will deliver the talk Keratectasia, the looking beyond the cross-linking. Over to you, Dr. Vishal. Meanwhile, we can take any questions from Dr. Pooja Rai, ma'am. Bharati, madam, you want to add something?
No, what nowadays lot of people, osmometers, they are coming, so they say it is lot of studies are there, so it's a very simple OPD based test. You have to just keep the machine there and it will collect the tears and will give you the osmolarity of the tear. This is one thing which is, but otherwise you have covered nearly everything. And nowadays you can even go to the trade and see lot of machines are there for the meibomian glands. Then you have this oculograph. You can see image the meibomian. You have shown the pictures also. But in practice, to start with, what you have said is the basic. We should first do the basic checkup and then only go for the higher end things. Basic checkup should not be missed, and you should also see whether the patient has severe allergy or they have or any systemic treatment. So systemic treatment, if any tablets, they are diabetic or not. So all these associated factors before you label the patient as dry eyes, and then you can start on cyclosporin and all. So immediately don't jump on cyclosporin and just happily prescribe. So all other factors ruled out. Proper connective tissue disorders also should be ruled out. Then come to the real dry eye patients, and then you treat them aggressively. Because
one case I would like to share that I had a case of a young boy who had a lot of acne on his face, and I was treating him with all anti-inflammatory topical drugs and all, but he never improved, and every month he used to come to me with the same signs and symptoms. After 2 months, he told me that he was on isotretinoin for acne. So that is one take home, that we should always ask for any skin treatment going on in patients. And then if we withdraw these drugs, only then they will recover from the dryness.
Exactly. Just like the lasik, we are asked the routinely patient whether are you any psoriasis is there or not, acne is there or not, or any HRT is there or not.
Ovarian cyst and all these people will form in a particular category. So you have to rule out all these things.
I think Dr. Vishal is ready, is waiting for the talk.
Thank you.
So what to thank you, thanks Dr. Pooja. We'll move on to Dr. Vishal's talk. Over to you, Dr. Vishal.
Thank you so much. Thank you, ma'am, and thank you the LOC and AIOC for giving this opportunity. I had to condense the whole IC into 7 minutes, so bear with me. Okay. So everybody who is sitting here is like a cornea specialist and a general specialist who deals with keratoconus once in their lifetime. They must have seen first keratoconus and then they are seeing more and more now. The keratoconus or the corneal ectasis can be divided into 3 parts depending on that when you see them, where they are presenting. You can have an early decade like keratoglobus or keratoconus, which is commonly seen. Then you have the PMD, which nobody knows why it happens. And the other one is post-refractive surgery, which is what I would say the iatrogenic ectasias that we deal with nowadays. Earlier we used to have only one answer. But yes, any ectasia you see, you do a cross-link. But now we have moved on. It does not mean I am against cross-linking. It is still the pivot. It is still the only FDA-approved procedure to stop any ectasia. But it has certain disadvantages. There is no visual gain. You can have scarring post-surgery. You will have post-response if you are dealing with late onset ectasias. So keratoconus, why are we having these problems? So we have to look beyond genetics. Everywhere, even the insurance company will say it is genetics, but we all know, and we have seen their papers, but still our books are still written on genetics, that yes, it's a genetic disease, but the mechanical factor, nobody is looking after that. We as clinicians are looking after that. We have been saying this for so many years. The inflammatory part, we have been doing that. We have been dealing with VKC. We have been seeing keratoconus more with people or children with VKC in their early life, and having keratoconus in their second and third decade. We've been seeing that, but still they are not, this is not a part of textbook. So whenever you deal with it, we have to deal with the demography. This is all part of the demography. Never forget, in keratocasias or keratoconus, spectacles and contact lenses, you should revisit these things. These are the things which we miss in clinics. We keep these on the optometrist, but we should do these more often. You can change the shape of the cornea and do a simultaneous cross-linking. I will not be going into detail because that has been discussed earlier. And you can change the cornea itself. So first part, demography. You can't change genetics, but you can stop the child from eye rubbing. You can stop any adult from eye rubbing. It destabilizes the cornea. You can take care of the atopy. You can, in susceptible individuals, females, if they are getting pregnant, you can always monitor them. Not all changes in the cornea require you to act, but if the changes in the cornea are persisting after 1 year post-pregnancy, you should do something about it. So don't worry. There is a high-risk characteristics. There is a paper available which states that if you have these high-risk characteristics and you feel that these are the things that are happening, you can have a scoring system where you can intervene early or where you should wait. For those who have a lot of irregularity, contact lenses can be given or spectacles can be given, depending on the cone size. If it's an early cone, give them a smaller contact lens. If it's a moderate cone, give them a hybrid lenses. If there is a very large cone and an ectasia and with a lot of thinning, but still you don't want to do the transplant, you can go for a very large 16 mm scleral lens. So these are the 5 basic steps which forms the, this is the complete treatment for dealing with ectasias. Looking at the demographics, looking at the spectacles, doing the cross-linking in the high-risk individuals. But finally, rehabilitation, you have to go back to your spectacles or contact lenses again and again. This slide is just for revision. Now we are shifted to mostly HPMC based riboflavin, only doing 9 milliwatt 10 minute protocols most of the times. And at times now even the riboflavin time has decreased from 30 minutes to around 20 minutes. Again, there are where you should intervene early and do something else to change the irregularity. To changing irregularity, as my friend discussed in the first talk, we can do the topo-guided lasers, or you can do the Athens protocol where you are not using a topo-guided laser, you're just doing the visual correction. But I disagree with him on the basis of as ma'am had pointed out, that 80 microns is too much. For me, if I see a 450 micron cornea, I would still be skeptical of doing it, because I don't do the topo lasers or any lasers in the corneas which are less than 450 microns, because I have to look at the residual cornea, that it should be at least 420, beyond 400 to be on a safer side. Advanced diseases, I usually prefer to do Intacs. Both of these are established and known to give us good visual results. This is what I follow for Intacs. You can have there is a whole paper on this, but the gist is, while planning the Intacs, you should first look at the cone, whether it's a centered cone or a decentered cone, because this will decide whether you'll be using a symmetric ring or an asymmetric ring. Then after looking at that, look at the asymmetry, that within the asymmetric rings, in the symmetric rings or asymmetric rings, what rings will you be using. Then your mean keratometry will be deciding that which type of ring you will be using. You can have, this is Intacs, not Kera rings, Intacs. So you can have SK ring or a regular ring. If your mean keratometry is more than 55 diopters, you should always use SK rings. The thickness is dependent on your dioptric power, which is the mean dioptric power, or the MRSE. If it is less than 5, I usually go for the 0.35s. If it is more than 8, I usually go for 0.45. Even for 3 and 8, I am using a 0.45 ring because it gives us a better result. In lot of asymmetry, single ring works best. And also in cases of PMD also, which will come later, single ring implantation works best. We cannot run away from keratoplasty in keratoconus. You will still have subsets of patients which will require you to do a keratoplasty. If you have scarring, you will have to do full thickness. If you have a full thickness scar, you have to do a full thickness grafting. If you don't have a full thickness scar, DALK works best, and femto enabled DALK is doing very good. It is better than your topo guided lasers at times. So only 2-3 slides left. So those of you want to read about the paper which I just described, so you can read that. Special point in pellucid margination is this, the one highlighted in yellow. No demographic characteristics is known to change the progression. Nobody knows why this happens. Even if you do your intervention, nobody knows how it will react. Post-LASIK ectasia behaves similar to your keratoconus. Sometimes people say that we should go and intervene early. I have had patients in post-LASIK ectasia where I thought that it is because of the inflammation that the patient was having, and yes, it was because of that only. I've been following this patient for quite some time now, and the patient has been stable without any need for any intervention. Thank you so much.
So I think we will take the questions in the last. We have only 10 minutes.
Yeah, we'll just move on the next speaker. We have with us Dr. Payal Mukherjee. So she will deliver the talk, when managing the Descemet's detachment landed us off into the other problems. So over to you, Dr. Payal. Meanwhile, we can take any questions with Dr. Vishal Arora while the Payal is, or we'll take later on.
So Dr. Payal, you have to finish in 7 minutes.
Okay. So my talk is on when managing Descemet's detachment landed up into other problems. I'll go really fast. So we all know what is Descemet detachment, and it is a potential vision threatening complication. Most common cause is a post-cataract surgery, though other surgeries can also lead to it. Risk factors include advanced stage, pre-existing fugues, hard cataracts, and some surgical factors like prolonged surgical time, trauma with the blunt surgical instruments, phacoprobes, etc. So it is detected by slit lamp examination and ASOCT, and management. Some Descements, like with small detachments or with planar and non-scrolled edges, resolve spontaneously. For larger, we need to do surgical descemetopexy. Others, we can also do a gas tamponade, suture fixation, descematotomy, interface drainage, and keratoplasty. So I'll discuss one case with us, a case with DMD post-cataract surgery. So a 46-year-old male underwent right eye cataract surgery elsewhere, reported to us with complaints of diminution of vision with hazy view after the cataract surgery. He was on topical medications, but there was no improvement in the vision. So on examination, in his right eye, the vision without glasses was counting finger 1 meter. Anterior segment showed pseudophacus, Descemet detachment in the central and inferior cornea, along with Descemet folds and corneal edema, and IOP was 14. So our management plan was right eye intracameral injection of a C3F8 gas in non-expansile concentration. So we went from 11 o'clock position, that was where the Descemet was attached, and we gave him a bubble. Then post-injection, we followed up the patient's IOP at 1 hour, 2 hour, and 3 hour after the procedure. And his right eye IOP was 16 after 1 hour, 16 after 2 hour, and 15 after the procedure. We gave him topical brimonidine plus timolol, hypersol, moxifloxacin, and 2-tab dimoxstat. But the real trouble started from the very next day when the patient presented to us in emergency early morning with complaints of severe headache, nausea, and pain and redness in right eye. On examination, there was severe conjunctival congestion in the right eye, cornea was hazy, but the Descemet was attached, AC was distended with the gas bubble, pupil was mid-dilated fixed, and the IOP was 56. This was when we realized that the gas bubble has expanded. So now what? First, we tried to manage the patient conservatively with injection mannitol, painkillers, antiemetics, tab acetazolamide, but all in vain. So next, the IOP was still 50. So next, we decided to take out the gas bubble, but very carefully, just to prevent the Descemet to detach again. And here, there is a catch. We made 2 attempts to take out the whole bubble, and in this procedure, we missed one small thing, that a small bubble went into the posterior chamber behind the iris. We can see the gas bubble in the anterior, in the slit lamp photograph. And in the subsequent follow-ups in the week, the patient presented to us with slightly improved vision, that is 6/60, but the IOP was still on the higher side. It was around 26. And slit lamp examination showed corneal edema, so we see we are underestimating the IOP. Descemet was attached. AC was almost nil nasally, very, very shallow in the center, and temporally, there was iris stuck to the posterior surface of cornea, as visible on the slit lamp image, the UBM, and the anterior segment OCT. So the last surgical procedure we had to do was to remove the stuck out iris from the posterior surface of cornea and to do a PI. So first we tried to remove the stuck out iris from the cornea with the help of visco expression with the visco cannula, followed by iris repositor. And when we could remove all the iris and we ensured that now the angle has become deeper, then we went for a surgical PI superiorly. So the PI is visible superiorly. Now we did visco washing and finally closed the wounds. Next day, the vision in right eye was 6/36. IOP has come down to 12. Anterior segment examination on slit lamp. Cornea had slight edema, but the Descemet was attached. AC has become deep. We can see in the slit lamp photograph. The PI was patent. Pupil was round and mid-dilated. And over the next follow-ups, over 3 months, the unaided visual acuity improved to 6/12 partial with the Descemet folds have settled and BCVA was 6/9. Cornea has become clear, Descemet was attached, AC was formed and deep, PI was patent, pupil was round reacting to light, and there was pseudophacus. IOP was 12. These are the post-op pictures after 3 months. Now literature says that why do complications occur with isoexpansile gas intracamerally? Either the gas is loaded in a higher concentration. I think in our case this was a mistake we did. We gave a 15% concentration of the gas, so the gas expanded. And when the volume of gas injected is more than the volume of the AC. Other complications other than the gas expansion includes the pupillary glaucoma, which is treated by peripheral iridectomy, subconjunctival or subtenon bleb, and malignant glaucoma. This is an important and serious complication, needs to be taken into seriously, and it is managed by lens aspiration with anterior vitrectomy. Also, there is some literature has noted delayed post-op migration of gas bubble in the pre-Descemet space, leading to redetachment of Descemet membrane again. So as a take-home message, I would say any expansile gas injected into AC should be given in isoexpansile concentration and in optimal volume only. Signs of gas bubble expansion should be identified and gas bubble should be removed as soon as possible. Migration of the gas bubble into pre-Descemet, posterior chamber, subconjunctival space, etc. should be meticulously washed out and removed as soon as detected. And in all these cases, a surgical or a laser PI should always be done prophylactically. Thank you. I think I've
Thank
been
you.
fast and
so committed. So I just want to add one thing. I think Varthi ma'am knows the center where I'm working. There's a huge bulk of cataract surgery. So there's a free gift. We are getting lots of DMD. So what I want to add that being a disc surgeon. So whenever you give the C3F8, specifically I saw the video. I don't know the same patient or not. Don't enter whole thing full by the C3F8. This is expensive gas. So whatever we are using, if we are using the C3F8 just like here DMD or for the even also bad your disc surgery or DMEC, then we are giving the at least 2/3 of the, because we know invariably it will be prolapse. And when if it is for the C3F8 for the DMD, I personally prefer inferior PI, because you don't want to be next whatever you saw the next morning or midnight the call from the patient. So it does no harm for you being inferior PI. Then everything is very much predictable. Or if you have a expansion or something, so you need not again enter by your side ports. You simply the 30 gauge needle, you just release the 50% plus 50% gas. So automatically instant you can see after 3-4 hours it attach and it will not never come out. So it will be solve your purpose.
So actually we have treated many DMDs and all were without complications. This was a special
no,
case.
We are using the 14%.
A series of complications.
Yeah, and this is very specific. This is your pupillary block glaucoma. Like that's it.
Yeah. Thank you.
That's a nice presentation.
Thank you, ma'am. Thank you, sir. Thank you.
You'll get the extra point because you finished before time. So we'll move on to our last speaker, Dr. Shefali Mujumdar. She will deliver the talk management of corneal perforation by different techniques. Over to you, Dr. Shefali.
Thank you, AIOS, for giving me this opportunity. I'll be speaking on the management of corneal perforation and desmetocele by different techniques again, so kindly bear with me. So, corneal perforation is different from laceration because of tissue loss, making the management more complex and challenging. In most of the cases, the diagnosis is pretty obvious, but sometimes in occult perforation, we need to take help of Siedel's test to confirm the diagnosis. There are various predisposing factors which may lead to corneal perforations. We all know those. And while treating these cases, we have two goals. First, we will have to treat the underlying cause, and second is the reconstitution of the globe. So while dealing the underlying cause, so we should always use preservative-free topical drugs as much as we can. If we know the cause is infectious, we can start fortified drugs, and it's also good to give systemic antimicrobial coverage. If the underlying cause is dry eye, then we should, whatever surgery we are planning to do, we should plug the puncta at the time of surgery. To promote corneal healing, oral doxycycline and vitamin C are really recommended, and they are very helpful. And if we are dealing with autoimmune association, like in peripheral perforation, we should take rheumatologist in the loop because we want to treat the patient as a whole. So various treatment options we have to deal with these cases. Number one, let's go with TABCL in 1 millimeter of perforation. So two things we should always remember. First, we should denude the epithelium because cyanoacrylate won't stick to epithelium. And second, we should dry the surface because we want slow solidification of the glue. Then just a tiny drop of cyanoacrylate will do, and then wait for, let it dry and then place your BCL, and that's it. So this was the case in which I have done TABCL, and you can see within a period of 1 month, the eye became absolutely quiet. But because patient was having dense cataract, so I had to do triple procedure for visual rehabilitation. Another good, technique is Tenon's patch grafting, and any anterior segment surgeon can do this because we all see these cases of perforated corneal ulcer in day-to-day practice. So usually I take Tenon's patch graft from the superior temporal quadrant, and here I am taking it. And with the help of fibrin glue, after washing it thoroughly, you just plug the defect, and I put overlay sutures. In small cases, I put 2 overlay sutures. If the perforation is 3 or 4 millimeter, we usually put 3 overlay suture in the infinity pattern. And you can see the suture which is going in sclera. I have done selective peritomy over there because we should never put sutures over the conjunctiva. They tend to get loose over the time. So we have done so many Tenon's patch grafting, and patients they really do well with this. Another multi-layer amniotic membrane transplantation, usually we reserve for the cases where ocular surface is not very healthy. Like this case, patient was having total LSCD and Sherman's was 0. And she was having 6 into 8 millimeter persistent epithelial defect. So we decided to go ahead with a multi-layer amniotic membrane transplantation with the help of fibrin glue. And because this was large, so I put 8 interrupted sutures. Otherwise, in most of the cases, I put 4 interrupted sutures to make it stay over there. Then I put a large, graft of amniotic membrane covering the whole of the cornea and put, running sutures all around. And in every case of, amniotic membrane transplantation, I always do tarsorrhaphy as well. So tarsorrhaphy always helps to amniotic membrane to stay longer. And this is the, result of this case. You can see the persistent epithelial defect. It was completely healed within a period of 18 days. And patient was very comfortable. If the perforation is associated with area of tissue necrosis, then you will have to remove the whole area, and then you will have to do, you will have to replace this with cornea itself. Like in this case, I'm removing it all, and I'm using the same derma punch for the donor as well as for the recipient. I don't take any disparity. And in most of the cases, I put 8 suture up to 5 millimeter of full thickness corneal patch graft, and they do well. So there are some of my cases in which I have done full thickness corneal patch grafts. But one thing we should always remember that in these cases, on a later date, we will have to do cataract surgery. So we should always try to save iris as much as we can, because for an uneventful cataract surgery, our pupil should be round and circular. Many crescent shape patch grafts we have done to save the eyes in cases of peripheral perforation, and sometimes, like this case, he was having this eye only, and in that eye he had this peripheral perforation, and we saved this eye, and he is having at least ambulatory vision for the life. This was also one very challenging case. This patient had electric burn, and in bilaterally he developed corneal ulcer, and he was referred to me with this 3 into 3 millimeter decimeter seal. So, and you can see preoperatively the thickness of cornea was 100 micron. So I decided to do, in this case, lamellar corneal patch graft. And but in lamellar corneal patch graft, we will have to first prepare pockets 360 degree with crescent knife to avoid perforation while we are suturing. So here I am done with my pockets. Then I did lamellar dissection of the donor cornea, and with this 3 millimeter derma punch, I am taking my lamellar corneal patch graft, and then I just place it over the defect and sutured it. This was the immediate post-op pic. Just after surgery, and then after a few months of follow-up, you can see the contour has become pretty normal, and you can see this is the host cornea, and graft is snugly and nicely fit into the defect. This is the recent pic of the patient who came after 1 year of follow-up in April, and he was having 6/9 vision in this eye. Lastly, with the large central perforation or perforation with large area of tissue necrosis, we have no choice. We will have to go ahead with TPK. So that's all I have. Thank you.
I think this is a wonderful talk.
Very good, very nice, very beautiful surgery videos, and very real time. It feels very encouraging, very nice. I think everybody
COVID,
has.
At least, just sorry to interrupt you. COVID gave us some of the new breakthrough in our mind, especially being a cornea person. We are not getting the tissue.
Yes.
Specifically, initially it was very difficult. Then the concept of the tenon patch graft come, and everybody trying to modify the things. Most of the time we have seen this in Bangladeshi patient over in Calcutta I'm from. So see, they don't have the tissue, actually it's predominantly Muslim country. So they have the Ganda sunflower, very nicely Ganda sunflower. Even Chennai also you see the patient those who came from the Bangladesh, they had nice. But the tenon one is really the new breakthrough.
Really helped a lot.
Help a lot when the tissue is concept of the tissue, specifically COVID time, whenever that there is a zero collection of tissue for the COVID, even also no your glycerin tissue also not available.
Actually, I'm working in the medical college, so my patients are very poor. So before COVID, I have never done Tenon's patch grafting. because in COVID, and I'm iBank in charge also, so I have plenty of cornea, no issue with that. So in COVID time, I started in spastic
COVID
grafting.
actually give us a new breakthrough that we can do it even the
Yeah.
tissue is not there available. That's it. Nice presentation, ma'am.
Thank you.
Excellent. Very good. Thank you so much. Thank you all the speakers. Thank you.
I want to share one.